Welcome, welcome. Hi, everybody. It is 11 on the dot. Amanda and IOCDF is probably super happy that we're like on time today. Although Mary's like, what's happening? Liz showed up 3 minutes ago. So we're always like right on time and showing up when we can. But I'm really excited for today. I'm really excited for this topic. As many people know, postpartum, perinatal, the whole experience with OCD is obviously very close to my heart as somebody who lives with OCD and has a 1 and 3-year-old. So I will certainly be sharing a lot of personal insight and experience, but then also clinical as well. And so we're really excited to have a guest who has expertise and specialization in this area so that we can really talk today about all the things related to being a parent with OCD or becoming a parent with OCD. And that's what today is going to be all about. But as you guys know, please say hi. Tell us where you're joining from, what your name is, who you are, things you want to know today, something fun, maybe a fun fact, all of the above. We want to hear. We want to interact and we want to engage. So please drop that information and comments in the right-hand pane. And of course, our panel today will be kind of like it always is. We'll do a little bit of Q&A, a little bit of education and discussion, and then we will jump right into active questions that you guys have. So anything related to OCD treatment, you name it, we are here. We're going to answer it, and I'm super excited for it. As always, a couple disclaimers. Please remember that the live streams are intended to be educational, and they're intended to be supportive and to hopefully help guide you in the right direction or provide some treatment recommendations, but they are not intended to replace therapy or treatment. IOCDF and or our live streams are not crisis hotlines, and so if you're feeling unsafe or suicidal, please call 988, go to your local emergency room or whatever your local emergency services are. So welcome, welcome. So excited to have you. Sorry for my dogs in the background. You guys know I never come home for live streams, but I'm home because we are in Houston where there has been nonstop storms and we still don't have Wi-Fi at the clinic, and evidently hotspots run out. I didn't know that till about 15 minutes ago. It said I've used all my hotspot data. So ran home to make it here. So I apologize for the noise, but so excited. So Mary, thank you so much for joining us. Dr. Mary Kimmel is an associate professor in the Department of Psychiatry at the University of North Carolina at Chapel Hill, UNC, which is also where Dr. Brimwitz is. Many of you guys know that. In her first 5 years at UNC, she served as the medical director for the UNC Perinatal Psychiatric Inpatient Unit, a national referral center for treatment-resistant perinatal mood and anxiety disorders and postpartum psychosis. During that time and then in her outpatient work, since she cares for individuals with postpartum OCD. Dr. Kimmel has served as the medical director of the NC Maternal Mental Health Matters program, a statewide consultation program in perinatal mental health that supports any provider caring for pregnant or postpartum individuals. A key component has been education to providers so that they're aware of perinatal mood and anxiety, including OCD, during the pregnancy and postpartum periods. Dr. Kimmel's research focuses on different assessments of stress in pregnancy and postpartum, and in relation to biomarkers from the microbiome, the immune system, and the autonomic nervous system. The ultimate goal of her work is to improve personalization of assessment and treatment of the parent and the child through the blending of family and dyad history, self-reported symptoms, and biomarkers. All that to say, your background and experience is all about parents who are either becoming parents or once you are parents and related to mental health in that arena. So you are the perfect guest. We're so excited to have you on. Love for you to kind of introduce yourself a little bit outside of the bio and tell us like why you fell in love with this work and why you do this.
So, a couple of things have really gotten me interested in the perinatal period, and then also specifically OCD. So in terms of the perinatal period, it's just such a critical time. I actually started as an OB resident and then realized I'm a psychiatrist. But just was amazed at how important of a time that was for an individual, for their family, and what the changes that were happening biologically, psychologically. And I really love seeing how our brains are adapting and changing to parenting, whether you're the birth parent or the non-birth parent, there is changes happening, and it's pretty amazing. And, helping kind of guide that. And so with that, some of those changes are those kind of what I call parent brain, parent thoughts, and those kind of protection thoughts, protection of our family, protection of ourselves. And those are, evolving, and we're, and our systems are trying to kind of figure all this out. And it involves, many components of, our systems, actually, including like the immune system. And so for me, that's just this beautiful kind of trying to figure out these different pieces. And then the privilege I have of being able to walk alongside families, walk alongside pregnant individuals, and be with them in this process, and then kind of help them figure out what's happening within their bodies and with their brains, and with the becoming a parent. And then in terms of OCD, I have a family member who deals with OCD. I think all of us relate to the intrusive thoughts and some of the OCD kinds of thoughts, and checking behavior and some of those kinds of things. And so that's been also something that I've been really passionate about. How do we understand those things, and how do we both support but also figure out what they're doing for us?
Yeah. And, I think that it's so important to be talking about this. Just because so many times there's so many preconceived notions about how you should feel, what you should think, the experiences you should be having when you're both pregnant and or in that postpartum period, or have this new baby, or as your children are growing up. And so I just want to first and foremost kind of level set and validate how challenging that time can be, in part because I feel like stigma is really high in this arena, right? Like, it's already high in mental health in general, but I would love to hear a little bit about what you've learned through clinical experiences and research around like the stigma and shame that also comes with dealing with mental health during this period.
Yeah, such a great point. And, we have these ideas, these ideals, that we get from society, that we get from culture around what is a mother, what is a parent, what is, that pregnancy is this amazing, beautiful time. And there are aspects of it that are. I mean, I just got done saying how amazingly cool I think it all is. But it's also, it really doesn't allow people to experience the breadth of experiences that are going on, and to be able to be with the complexity of what each person is experiencing. One of my mentors, Kathy Wisner, used to tell a story about, she had a patient who was pregnant, and she went to her attending, and this was, fortunately, I think we've moved beyond this, but she went to her attending and said, I think this patient's depressed, and her attending said, oh, that patient can't be depressed, they're pregnant. And so that's where we were moving from. And you get that from sort of these images we have of motherhood and parents, and I think those are, those serve a role, but also they don't allow people to have the complexity and the beautiful nuance of all the emotions. And as I like to say, mental health is all of us. I mean, I think there are medical conditions that run in families, and these are medical conditions, just like other medical conditions run in families. And they run in families for a reason. They run in families because they do serve a purpose. But also there is mental health is this larger complexity of all of our kind of mental life and our social experiences, and how, the things we're doing, and how, kind of the things we, choose to do, our behaviors, our habits, kind of all of these things. And so mental health is all of us, and we all need mental health support at different times. And I think in pregnancy, everyone does, but I hear the conversation changing, and I find that really heartening that it is changing, where people, there was a lot of fear around, if I am seen, if I tell anyone I'm struggling, they will automatically think I'm a bad parent. And I think we're beginning to change that thinking, and that actually by talking about the complexity, talking about the struggles, that actually those are really good parents. That's how we support people,
100%. And I think that, I'll share some of my own experience, but we'll get into that in a little bit, because there's a lot there, and we'll unpack that together in different ways. But I would love, I think that, it is so important for us to just be talking about it. And, that's one thing I will say, you guys, I'm just so proud of the entire OCD community and advocates, is that I feel like we have more people speaking up and talking about what it's like to live with OCD during all different timeframes in your life, childhood all the way to, geriatrics, including these different important phases, right? Going to college should be fun and exciting, but it can also be triggering and terrifying, right?
Yeah.
Having a baby should be amazing, and it can also be really hard. Like both things can be true at the same time. And I think that it's so, so important that we're talking about it. And so, yeah, let's get to treatment in a second. But before we do, I would love to hear a little bit about statistics and numbers and kind of how many people do you find and see that are diagnosed or really witnessing or experiencing anxiety and OCD for the first time in the perinatal period versus what is the statistics that we're going to experience an increase in symptoms if we are already have been diagnosed prior to the perinatal period?
Yeah, it's a great question. And I think it really gets to part of our challenge is that, that OCD is an umbrella term. And within that are a lot of different people with different components and different experiences and maybe different, components in terms of what's, whether it's the immune system, the stress system, the autonomic nervous system, different components that may be playing a role. And so, we know already, so it is certainly for people who've already had a diagnosis, have had that since they were a kid, since they were a teenager. This is a period of time where this is a time where those symptoms can be reactivated due to the psychological stress, due to the huge amount of physiologic stress. I mean, pregnancy is a major physiological stressor, but also becoming a parent, even for the non-birth parent, is a huge stressor, physiologically as well, with the sleep deficit and all of that, right? And so though that is a time where that certainly for some people, that is their trigger to kind of their episodes or their worsening of their symptoms. But we also know, interestingly, that it is a period of time where we will see an increased prevalence. So you will see, about 4% of the population will have postpartum OCD, and it's higher, and I actually think that prevalence is probably an underestimate. And I think these things are very much dimensional. And so we are missing people who are keeping their symptoms to them, like are really kind of trying to, keep their symptoms to themselves, that are, because of stigma, because of those reasons, are really not seeking out help and not seeking out diagnosis. And so we're probably missing a chunk of people. And then we also know, and I think part of the reason we see that is because there's also this changing that is occurring, and actually intrusive thoughts. So these kind of like thoughts that come, like you're about to take your baby down the stairs, and suddenly you have this image of, what if I drop my baby? And for different people, that image can be a thought. It can be a really powerful image, really, just sticking with you image. And so that is pretty common. And we actually know that probably is an experience that many people experience. And then the question is, how often do they have that experience? And then how sticky is that? And how hard is it to get away from that thought? And so I think that's where it really is hard to know how many people are experiencing this, because it is I think we have people who are kind of different places along that spectrum.
I'm like smiling because, so I'll give y'all know I can't not share personal. I tried to for a little bit, but I can't remember where I was, but I think we're in my daughter's room probably like a month ago. And I looked at my husband and I was like, do you get weird thoughts about our kids? Like, I was just curious. And he's like, all the time. And I was like, oh, okay. So validating to know, like, because you hear, like, that everybody says, like, oh, you're not alone in this. You're not the only one getting it. And you believe that. But I was like, I just want to make sure that's actually true. And he's like, yeah, all the time. I was like, what do you do with them? He's like, nothing. I just keep going. Like, it was so good to be like, yeah, and that's OCD treatment. But like, okay, this is real. Like, this is, everybody feels this. Everybody gets these. The difference is, for those of us with OCD, they get really sticky. They're accompanied with feelings, right? Anxiety, distress, all these moral questions and all these things that happen. And so now we have to treat them because they become really disruptive. But the thoughts themselves are not actually unique, right? It's not special that those of us with OCD get those. It's just that they're like combined with these other things that then make them problematic, right?
and being thoughtful. I mean, really, it's sort of this thoughtfulness that is, there's sort of the like, oh, I had that weird thought, oh, whatever, but the sort of like, what does that thought mean? And like, what do I do with that thought? And I really do think they are, I mean, think about the thought of, the thought of dropping your child or, or even purposely dropping your child kind of thought. And that's like, that's a weird thought. Why would I have that? But there's also this, like, it's like protection mode, right? It's like, I need to think of every bad thing that could happen and try to protect us, And so, and even sometimes protect my child from me because, I need to really protect. And so I think those thoughts really are about, like how some of it is like, how thoughtful are we about them, and how much do we kind of like have trouble kind of letting go of them because we're trying to figure out what they're doing,
Yeah, no, you hit the nail on the head. And I think that, I think that it's interesting because when you have kids, right, there's, for somebody with OCD or anxiety where we know thoughts are a little bit stickier, it makes total logical sense to us as clinicians that, like, well, of course those are stickier, right? Is they're about your own kids. It's about your own life. And it feels like really hard to let that go.
Yeah.
And they're actually no different than any other random intrusive thought that you or somebody else gets. It's really because we're responding to them, because we're being thoughtful about them, because we're trying to decipher them or get rid of them, that they become empowered. So I would love to talk a little bit about presentation and what you see most frequently. So let's kind of differentiate. So let's start with anxiety and not OCD. So tell us a little bit about what anxiety looks like for individuals in the perinatal span, and what some of the common signs and symptoms you see, or that would make you say, okay, like you should really be thoughtful about getting appropriate treatment for this.
Yeah, great. And anxiety too, it, really is this wide range. And so, it can include in it, things that are very physical. You look at some of our kind of even within generalized anxiety. And so kind of the generalized anxiety, I tend to think of that being worry about kind of everyday things, but really all so much of the time, like a good portion of the time. But even in that definition, it's got things like, because it's also physical. So you have like the muscle tension and like, jaw tightening. And so kind of these physical manifestations of stress and kind of just continuing to kind of worry and worry over, do we have enough money? Do we have all the things we need? Just kind of those continued worry about, and how am I going to navigate these things? And then, that also can be sort of out of the blue, just full body panic, and so that can be, so panic that you begin to, that you have these, shortness of breath, you feel like you're going to have a heart attack, and then that can certainly, I think, can be then can either happen sort of, in a setting like at the grocery store. And then that, it's like, then this kind of panic of not wanting to, and then worried about my child and I are at the grocery store. I will say in pregnancy too, there's all these things physiologically happening to our cardiovascular system. And so some of these things are, like as you get further along in pregnancy, you are getting more short of breath, right? And so there's kind of this manifestation of all these things, then getting, and then not, being unsure, well, when is this dangerous? When is it not dangerous? And also I have patients where, they've talked to me about feeling a lot of anxiety, this kind of both the thoughts, the worried thoughts, about, am I okay? Am I going to make it through this delivery? I've had patients who've had friends who had major complications, people who have known people who've lost people, during delivery. And so, there is this complexity of all of that kind of this. And so, but then I've also had patients who, as it turned out, they did have a elevated blood pressure, like they were actually moving into preeclampsia. And so, I think it's key to kind of these things so they're the thoughts and the feelings and the experiences. And so it's this balance of continuing to kind of look and see what they are, but make sure you're talking to people about them. And as providers, we have to try not to, sort of dismiss either way. say, oh, that's all, that's all in your head. But also, help people recognize, like, yeah, I know, like, let's help you kind of understand what anxiety is. Let's help you understand these thoughts and what we can do about them and what we need to get more data on, as I like to say.
It's so interesting because so one of the places my OCD kind of showed up in pregnancy, well, lots of different ways, right? But one thing I recognized was so I'll talk about two things. First, let's talk about pregnancy. So during pregnancy, I think I was so expecting my OCD to show up that I had such a good like team and preparedness sort of kit ready that I wasn't ready for the general anxiety. So actually, like I was talking about, like that threw me for such a loop of like, why am I just feeling anxious? Like, what is just happening? Which we like, again, I was smiling earlier as you were talking, because I'm like, part of it is like, yeah, like general worries about finances. Like, of course that goes up when you're gonna have a kid. Like, like so many things happening, like everything changes, your job questions, you're like, it's normal that a lot of it is like, do I love this job enough to like keep doing this while I have a baby? Like, do we have enough money? Do we have to change our lifestyle? Like all of that is normal. And that is something that actually surprised me, because I feel like I was, as somebody with OCD, I feel like I was already like, oh, my OCD is probably going to increase. I should be prepared for that. I know that this is going to happen, but I wasn't really ready for the general anxiety. I had preeclampsia with both of my daughters. And so preeclampsia, for those who don't know, is when your blood pressure increases and can be dangerous. And so you need to have that monitored and watched by your doctors. I found myself in this phase where I was like borderline with both. So it was like, oh, there's like traces of protein with my first, and then blood pressure slowly started to rise. And then it got to a point, but before it got to the point of like, we have to deliver at 37 weeks and there's nothing we can do, I found myself being like, well, is this real? Or am I making this up? Like maybe I just actually want to have the baby early because I hate being pregnant, because I did hate being pregnant. I was very sick the whole pregnancy. And so I found my OCD latching on to like, are you like that kind of harm OCD, right? Of like, are you just like, it's just what you prefer, but it's actually like not what's in the best interest of your kid. And so like, if you tell the doctors that they can induce you early, is it really like, and so I found myself, I did ask my doctor, it wasn't reassurance. I don't think it was really a question, because I only did it once, but I did say to my doctor, like, what would you do if you were me? And she's like, well, I would induce at 37 weeks considering your circumstances, right? Because it was, again, considering my circumstances. And I was like, okay. And I was able to say, all right, then that's what I'm going with. Like, I am not right. And so I do think there is this piece where I've heard a couple of people lately that I've been meeting with say things like, yeah. And I was like really genuinely like worried and questioning about my kid, but like, I didn't want to call them because I don't want to ask for reassurance and I don't want to be that mom. And I was like, okay, but wait a second. Like both can happen, right? Like be careful that you don't go into these stressful new situations and treat everything as OCD, right? Like me actually getting one question answered about preeclampsia that I know nothing about, where my fetal maternal specialist who I'd been placed with knew everything about, like there was nothing wrong with me asking her one question to get clarity. But there would have been something wrong with me calling her every day afterwards to confirm that that is actually what she recommended and that makes sense, right? And so I think it's important to separate out too that like pregnancy, postpartum, it's new, it's different. You're not going to have all the answers. And so it is okay also to not treat everything as anxiety and OCD, but to know the difference of like, when is this a genuine question versus this is my anxiety talking.
Yeah, I love that, because I really struggle with that, this idea of even thinking about kind of, the typical treatments for OCD in terms of not making sure people understand not to be getting reassurance. And yet pregnancy is a time and postpartum is a time where people need some reassurance. And so, and then if you have a medical complication like preeclampsia, I've worked with parents who've had preterm birth babies and sort of the checking that goes with that, and the sort of hypervigilance around their baby, but they're also being told by their NICU provider how vulnerable their baby is to infection, and so that's where I kind of think some of this, again, it serves a role, like these thoughts really serve a role and are there for a reason. And so there is this balance of like, how do we kind of, where do we find the right balance, the right amount? Like asking to have an ultrasound every day is actually going to make your anxiety worse. And even though it feels good in the minute you have the ultrasound or you do the Doppler, but then also we shouldn't not ever do the ultrasound or the the
Right.
testing,
So,
you
and
know?
that's the same in OCD treatment, right? Like
Yeah.
like I'll have patients, I had a patient recently who they had this incident that happened, or this information they received at work that they needed to ask a question about it. But some of their family was saying like, well, asking that question is OCD. And she came to me and I was like, actually, like, choosing to not ask that question once feels like avoidance. And she was like, thank you. It was like, actually, like, I feel better not asking because I'm afraid of what the answer might be.
Yeah.
And so this is where it's like, be thoughtful and know yourself enough to know that, like, actually, that's just like not getting an ultrasound at all is avoidance and
Yes.
not helpful and not what would be recommended. But getting a daily ultrasound is problematic and feeding anxiety and might have these other issues with it or whatever could come along. And so being able to really be thoughtful about that. And people will always ask me, I get this question all the time where people say like, Liz, how do I know when it's OCD or not? And my answer to those of y'all know, because my answer is never reassuring, is you know when it's OCD or not. Like, you do. Like, I live with OCD. I know when it's probably OCD. And if you're thinking it might be OCD, go ahead and assume it's OCD or anxiety, right? But like, you know when it's not. When you're like, no, I genuinely am curious about this. Like, no, I really do want to understand this, right? So like my doctor, for example, and again, this is not advice because every situation in pregnancy is different. You should only do what your doctor recommends. But my doctor had me checking blood pressure twice a day. I had to check it morning and night. And right, like that was what she asked me to do. And so I would check it morning and night. Now, if it hit a certain number, for me, it was if it hit 160, I had to send her a picture. And then she would give me instructions of like, if I needed to retake it again to double check that and like what I needed to do. But again, like somebody would say, well, checking it twice a day is OCD. It's like, no, that actually wasn't OCD. That was like what was needed for my condition, which could have become serious. But like, if I would have then taken that into checking it every hour when that's not what my doctor recommended for me, that would have been my anxiety.
Yeah.
Yeah. So important to be thoughtful. So let's talk a little bit about postpartum. I remember, and everybody has a different experience, but I had preeclampsia and was vomiting. No one wants to know that. I know that. But very sick and vomiting my entire pregnancy. So honestly, the second I delivered, I felt great. I was like, and I know, again, different for everybody, but like, I was like, oh my God, like I don't feel sick. Like that was amazing to me. And I remember having my first daughter and coming home and kind of feeling like great. Like I was like, I feel like kind of euphoric. Like I feel great. This is awesome. It was probably like 2:00, right? Family came like over a little bit. It was COVID, so not very much, whatever. And it was probably 10 p.m. I don't know what happened to me, Mary, but I just started crying. And I remember looking at my husband. I was like, is she okay? Is she going to be alive? Is everything fine? I don't know what to do. Like, why am I so sad? And I'm just crying. And my poor husband was like, what's happening? What do I do? Like, I don't know how to respond to this. Like, what's happening with my wife? Right. And I was so grateful. I'll never forget. I had texted my cousin who, like, we're not even that close, but sometimes these like God things happen. And I had texted her, or she had texted me to say congrats. And she sent me a text right around that time. And she said, just a warning, the couple days when you first go home are an emotional roller coaster. You're going to be happy 1 minute and crying the next. And I remember being like, okay, maybe this is like, okay. But no one tells you that. Like, why they don't tell you that when you leave the hospital is so bizarre to me. And so anyway, what's interesting is, once again, I feel like I was very prepared for OCD when I left, because that had been like, okay, if OCD pops up, and I was so expecting OCD to be really loud. And depression, man, it really hit me postpartum, these waves of depression, especially with hormonal changes and feedings and stuff. And that I was like not expecting. So talk a little bit about just like what's the norm, but then how do people help, how weather through it, so to say.
Yeah, this is so good. And I mean, what you were kind of describing sounds like, in one way is postpartum blues. And, with this term that people have used for a very long time, kind of, and there's a challenge to that, which I'll get to, but so the postpartum blues, and it really recognizes, I mean, when you deliver the child and then deliver the placenta, you had the highest amounts of like estrogen and progesterone that your body has ever seen. And then with that delivery, those really come down quickly. And so that's a huge adjustment. And then there's all the other adjustments that are happening with your body, you know, gearing up for breastfeeding, and the difficulty that may, you know, there may be difficulties with that, and kind of irregularities of those hormones, and you know, the immune changes that are accompanying all of this, because there's sort of this ramping up to get you ready, which is part of where I think preeclampsia, you know, comes from, is this like ramping up to get you ready to deliver. And so there are all these things happening. And so 80, you know, the numbers used to be, what I used to teach medical students was, you know, postpartum blues is like 80% of people. So, which is really basically everybody.
Yeah, all of them.
And it is kind of, and I used to give this example, like it would be, you know, I'm asked to see a patient because they're like, you know, they are yelling at their husband because they're reading a magazine, you know, they suddenly like were crying because they just feel so like this, like kind of how funny that their child has to wear the glasses because they need the Billy light, but also their first sunglasses, but also they're really sad their child needs that. And so like this kind of complex up and down of things, right? And then when is it depression? And so, you know, and that again is this like spectrum, right? And so, you know, if those, and I think some of it is one of the important things is like level of hope. How much hope do you have? Like how much confidence do you have that this will be okay? And then there is the, you know, but also then it kind of, you know, and then if you have a history of depression, this may feel like depression you've had before, then you kind of know. But if you haven't, and we also know the postpartum period is, interestingly, it's this period of probably, you know, we know some people are sensitive to that drop in hormones, that they're kind of the first time they're seeing that, their body's seeing that kind of change. But also it's all the other things like not getting enough sleep, and the kind of the changes that are happening, the complexity that happens around trying to breastfeed, and or just make sure your child's getting the nutrients they need. Do they, you know, are they growing properly? You know, so there's kind of, so depression too is this spectrum, right? And it's about kind of figuring out for you the experiences, but I think the key kinds of differentiating things are things like how much hope do you have? Are you able to have brighter moments? Have you kind of, or do you feel like you've gotten stuck in this like this place of not being able to feel things, or stuck in this place of feeling kind of, and sometimes it's anxious depression. And so then it's kind of this like just constant worry, but it's also like kind of this feeling of dread, which then kind of can lead to hopelessness. So it you know, different people have different experiences of postpartum depression.
And I think that for me, one of the things for many of us who've had depression in our life, it's kind of familiar, right? Like, or it could be to a degree, like you're kind of like, I know what this is, but it was so heavy so fast.
Yeah.
Like usually depression for me had been a little bit slower of like, oh, like I'm starting to feel a little bit down. And then I start to behaviorally act as though I'm down, staying inside or not going out. And then I like feel worse. And then it becomes where I can remember literally like, I'll give specifics because I don't mind, but like pumping, like going into pumping, feeling okay. And within 5 minutes, literally feeling like, oh my gosh, I feel this like immediate dread, like immediate. And that was so bizarre to me, you know? Yeah. And again, I want us to be talking about it openly because those are the things that I wish we talked about. Like, I wish somebody would have said, this is going to happen, or this might happen, and it's okay. And it will pass. And here's kind of what you should be prepared for and how you can expect that to go.
And sometimes it does mean, I mean, like that kind of that milk letdown, that dysphoric, you know, kind of feeling that some people can get with the breastfeeding. You know, I've had patients where that meant we did need to think about what, you know, a treatment. And then for other people, it is kind of, oh, now I know what that is, you know. And so we do need to be talking about this and knowing that we can help people kind of navigate and figure out what they need to navigate this time. And it is, to your point, like it is, I mean, I've had patients describe, like, and it varies. I've had patients who describe the minute the placenta delivered, like they felt like a curtain falling, and so that's someone who's really sensitive to that. But then I've had other patients, when I was on the inpatient unit, sometimes we'd have patients come in and be admitted at like 5 months because, or even 9 months, because, and we know actually 9 months is a really vulnerable time, actually, when you look at like data across individuals, across populations. And so, because for different people, they're the different contributors. And so, for some people, it's like a building on of kind of things. And for other people, it is this real sensitivity to that immediate change. And so, yeah.
Yeah. And I think that it, man, I want to talk about the last thing I felt and describe it and see if people can relate. But I think one of the things I wasn't prepared for either during pregnancy, sorry, more postpartum actually, was the identity shift.
Oh, yeah.
Yeah. And I've talked to my husband a lot about this of like, man, like, was that hard for you? Like I felt like immediately I was a different friend. I was a different wife. I was a different coworker. And I didn't always like that. Right. And the capacity that I had for others had to change, and it did. And right, there was all these like immediate shifts that people tell you your life will change. And you're like, oh yeah, maybe not. But like, what I feel like I didn't understand is that the way I understood myself, like my own identity, would also need to go through a drastic or would go through a drastic change. And it's interesting because it makes me think a lot about OCD treatment, right? Mm-hmm. Where we actually talk about how so many times people, right, our goal is like, I just want to get better. I just want to have good treatment. I want to get better. But then what we see is a lot of people saying, okay, I'm better. And kind of like, now I have to redefine who I am. Right. And it's really hard. We talk a lot. We've talked about like grieving, what OCD and anxiety has taken away from you, but also like all the energy and things it now takes to be like, okay, now I'm in my 30s with successful treatment, and I have to figure out who I am. I also have to grieve what I lost, and I have to, right. And to me, I felt a similarity a bit with that, with kids, right? That like, it was like, oh, like, I don't have that same time. I can't just go run to the store in the evenings. I've got a kid sleeping, or what, all these different things that happen. And so I'm curious if like that's normal, but also if you see that identity shift also contributes, because I know I see it with myself and my friends, to people's anxiety and or OCD symptoms.
Yeah, absolutely. And I think, this is something we really need to talk about and give people space to talk about what their experience is. Because I think if we come in, if you're coming at this view that, oh, of course, becoming a parent is this amazing thing, and, there's no, no challenges to that, people need to have space to think about, how does it change things? And what are the parts that I need to grieve? It is okay. I think we talk a lot about, actually, on the perinatal psychiatric inpatient unit, we have a chaplain who would do this amazing group on, and it was a spirituality group, but really it was on concepts like grief, because there are many things that we are sort of in this transition that you are needing to kind of let go of things, but also think about what is new, and, and be excited by those things, but also those are, can be overwhelming and sort of uncertain, and I think particularly in our society where, we don't get a lot, and like in the US where we don't get a lot of maternity leave, we don't get a lot of parental leave, it is really hard to think like sort of this, like we're not given a lot of time to think about this transition and to like kind of be able to and I tell people, you need to remember that just because you became a parent doesn't mean you stop being some of the things you were before. And it's okay to want those things, and to figure out things that you want, and things that may come back later in life. Maybe, right now you can't, maybe there's a hobby you can't really do right now because you're, getting up every 2 hours, but too tired to do anything else. But although
I will tell you, one of my hobbies is coffee, so it was an amazing thing I got to enjoy a lot of.
Well, that's convenient.
Sometimes it works out for you when you're on 2 to 3 hours of sleep consistently.
Yeah, exactly. Yeah. So
I totally agree, and I think that I just want to point out too that like the way you handle it is there is no right way.
Exactly.
And I say that because, so I went back to work after like 10 days with my second daughter because both work stuff needed to, but actually I really needed to.
I know.
And I felt people, there was like a lot of people kind of made me feel guilty of like, why are you doing that? You shouldn't be doing that. You know, oh my gosh, like this is ridiculous. And what I finally had to say to people is like, I actually need to do this right now. Like I need, and I was blessed enough to like have flexibility that I could go in for a few hours and do, but like I needed to have work, to have my passion, and to not lose that in that moment. And I actually ended up taking some maternity leave later when my daughter was 6 months, because that was more what fit me. Like the newborn stage was really hard, and like I needed to have work, and I needed to have some things I could feel really good about. And so I say that just because, remember, like there's not a right or wrong, right? And we live in a world where some people get 6 months maternity leave and some of us don't get that. And like it's figuring out what works for you. And for some people, 6 months maternity leave like actually may not be the best thing because of like their mental health and what they need that might look different. And so just being cautious too about the way we I don't know what the right word would be, but like the way we speak to people's experiences or the way they're responding to their experiences, right? That it is different for everyone. For some people, breastfeeding is easy. For some people, breastfeeding is really unhealthy, right? For some people, going on a walk with your kids is really useful. For some folks, it's really painful and not what they need, right? So there's no right or wrong.
No, exactly. I think that is such a key piece. There is no right or wrong. And we are constantly sort of, there are messaging that there is, and I'm glad you said that. Like I had a research study going when I had my, my second child, and that research was important to me, but it was actually important to my family too. Like we made it work, and, and this is about kind of families and supporting families, and my spouse, was able to be, do some of the caregiving so I could go in and see participants in my research study, and make sure that they were taken care of. And so, we really need to have this space of it's individualized and it's not wrong or right. And we need to have discussions about, and how do we then support individuals, but also how do we support families and think about this from a family lens.
Yeah, exactly. 100%. So we did have some pre-submitted questions. And so I would love to get to some of those as much as we can. I love y'all's comments, and so many folks are talking about just kind of both medication experiences, but also how some therapists are trained as grief counselors. And sometimes it's hard to take care of yourself, more the less kids, and yes to all of the above. So let's hop in. So the first question is, we know what perinatal OCD is. We talked a little bit about that, but what is perinatal OCD and how does it differ from other forms of OCD?
It's a great question. And it's a question that we don't have an answer to. And that's some of the work that we're doing. I work with, we have a study with John Abramowitz at UNC and with Jerry Nestat at Hopkins. And part of that study is to kind of think about some of these concepts and again, I really land that these are umbrella terms in there. So there are some people, for them, it is their OCD, and it is kind of, and it's being exacerbated by some of the things that are happening. And then for other people, it is very specific to the perinatal period, and to those kind of thoughts are really focused around the baby, harm to the baby, and those kinds of things. So so I think we don't actually know exactly, like, kind of how, I think, as much as kind of the distinction, and so that's part of what we need to keep figuring out. And I think probably, again, like, is it for some people, is that change in hormones, is that a trigger? Versus for someone else, maybe it's the immune system that is really that ramping up of inflammation that's occurring. And for other people, it's the sleep deprivation. So, I mean, it may just be, or it's the psychological, like, who am I as a person? So it's like all these pieces, right?
100%. What are some causes or key factors that might contribute to perinatal OCD?
So those things, I mean, I think, there's some interesting work around kind of understanding changes in estrogen and progesterone. I have a colleague, Dr. Lauren Osborne. We're looking at allopregnenolone. So that's actually, so progesterone then becomes allopregnenolone. And so kind of thinking about, is there a role for that? And I really do think there is a role for the immune system in this, but again, the immune system also isn't monolithic, and it is this complex mix of different components that are trying to kind of find balance. And so I think those components from a biological level, but I also think it is important to keep in mind the kind of, how important are our thoughts to us, kind of how important are, when I have a thought, what do I do with that thought? And that's, also figuring out, it is like, we shouldn't ignore our thoughts. It's what makes us human. And, so kind of that balance of like how, what to do with different thoughts. And then what to do with, and behaviors, and which behaviors are helpful, you're, how many bottles do you have to wash, and so that cleanliness and kind of those kinds of things, like what is like routine and needed, and what part becomes so absorbing that it keeps you from doing the things and being able to enjoy the things you want to enjoy.
100%. Those sanitizing of bottles that is real. What are some of the common obsessions experienced by mothers with perinatal OCD?
So they're quite a range. I mean, I think, so the ones that people I think more easily talk about are worry about germs, worry about contamination, worry about things like dropping the baby. Maybe it's a thought about knives, and some of this can be a thought or it can be an image. So it can be the image of the knife in the soft spot of the baby's head and being like, I don't know how it got there. I don't know why I have that it's a horrible image. Of one that's kind of, is like seeing your baby in the microwave. And so it's like this funny thought, like that is not that uncommon, is like, oh, my baby's the size of the microwave. And then sort of, whoa, why would I think about my baby being in the microwave? But then also it can be thoughts like, it can be sexual thoughts. It can be worried about, sort of sexual harm to your baby. There can be, worries about those kinds of thoughts. And those are much harder for people to talk about. And so I think it is important that we kind of, just like we have the Yale Brown, the Y-box OCS symptoms, it goes this whole range of things. And so we see that in the perinatal, it can be a whole range of things. And some of them are easier or harder for people to talk about.
100%. We have a live question that we'll get to. I want to get to a couple more. Why do you think, you talked about this a little bit, but in more detail, but like, why do you think perinatal OCD is often misdiagnosed or overlooked, and what consequences might come from that oversight?
I mean, one of the challenges is we actually don't have we don't have good screeners that are used regularly. So if you look at our most common screeners for postpartum depression, it's the PHQ-9, which is basically symptoms of major depression, or the Edinburgh Postnatal Depression Scale. And it tries to have 3 questions about anxiety, but it doesn't have a question about intrusive thoughts. It doesn't have a question about kind of checking behaviors or any of those kinds of things. And so it can be really easy to miss those things. And those are good starts. I think when I go out in NC Matters and educate providers across North Carolina, I really want them to know that's a good start. But we also need to make sure that we're using that as a conversation starter, and that you probably also should be, kind of saying, many parents have kind of upsetting thoughts that come to them about the baby. Have you had one of those thoughts? Let's talk about it. And then there are some screeners like the pregnancy anxiety screening scale that actually does have a few questions about OCD, as well as actually questions about all the range of anxiety, from social anxiety to panic to trauma responses. But that's 30 questions. And so I think, there are tools that we can use, but also it's about really just making sure people feel like they can talk about what they're experiencing, and that they have space to talk about what their thoughts are and what they're experiencing, where they feel safe to talk about those things.
100%. What was the next question? What are some signs to look out for that might indicate a mom is experiencing perinatal OCD? I feel like we've talked a lot about that, of like intrusive thoughts, excessive kind of intrusive thoughts, but accompanied with fear. But then certainly if you start avoiding, if you're starting to feel distressed by them, I think those are really important signs. How does perinatal OCD impact the overall mental health of well-being mothers, as well as their relationship with their infants?
So this is one thing that I think is really important. What I used to see a lot on the inpatient unit was patients would feel like they weren't connecting, and yet the nursing staff would see them with their children and be amazed at what they were doing. And so I do think it is really important for people to recognize that even when you're not feeling disconnected, it is important to recognize that that's the worst part about it, is you don't get to feel it. Yeah. But also I think we need to do better at how do we in different settings. How do we in a pediatric office, how can we help help a dyad, because really for that first, year, they're still like, a unit. So, and maybe a triad or a quad even. And so how do we help that unit, and how are their interactions and support them in that? And so, we think a lot about the ways that we can kind of observe, but also help people kind of experience what they're feeling, and talk about it. But I think, we probably all need more support around kind of how we becoming a parent and navigating our child, because each child's needs is going to be different. And we're kind of trying to figure out what our child's needs are and how we interact with them. I mean, they're becoming their own person with their own kind of personality.
Yeah, I also think that it's interesting and so important that we are able to really hear what someone's saying. So I remember when I was with my daughter, I don't know, it was probably a month or two in, and I said to my husband, I said, I'm feeling really disconnected right now, and I'm really struggling. And his response was like, "That's not true. You love her so much." And I was like, you are not hearing what I'm saying. Right? But it was like, no, but I'm telling you how I'm feeling right now.
Yeah.
I didn't say I don't love her. I didn't say I'm not doing the tasks I'm supposed to do as a mom. And it doesn't look from the outside, just like those nurses' observation. It looks like things are going well, but I'm telling you. And what I really meant was I'm feeling depression. I'm feeling some dissociation and some I'm struggling in these different ways. But you don't say it like that, right? You just say I feel disconnected. And then your loved one is trying to be supportive. And they're like, oh no, you're not at all. And it's oh my gosh, I feel more disconnected now because you're not hearing me. So yeah, any ideas on how family members and friends can offer supportive and helpful statements?
That's important. And actually, I mean, one of the things that I always do like to talk about too is to not make assumptions about what someone is experiencing either. And so there is kind of this, not to give them space to experience what they're experiencing. And I think that's where sometimes things get that's where people say, oh, this is just postpartum blues. You just have postpartum blues. You'll be fine. You're doing a great job. And it's good to hear. I mean, we all, I think we should all be encouraging parents that this is hard work. They're doing a good job, but, and so, where that comes from, those kinds of, saying those things. But also we need to, experience what we're experiencing, have space to talk about those things. And then also space to figure out, is this then becoming postpartum depression? Is this becoming perinatal OCD that is actually does need treatment? And that is impacting us, but, is impacting us. And so, and even kind of, I think I treated a lot of patients with postpartum psychosis on the inpatient unit because we were a referral center. Right. And so, we would sometimes have patients say I'm having this really upsetting thought. And I think the other extreme is to say, oh, that's just your intrusive thought. So you have to be careful to give people space to talk about what they're experiencing, what it means to them. And that also may come and go, what they experience. And so we need to give space to people, non-judgmental space, and be supportive of them that pregnancy is hard, postpartum is hard, being a parent is hard, all these things. And there's a lot of, there are a lot of, not positive thing about some of that. We need to talk about those things. I can't even say negative. I'm not positive, That's how hard it is to talk about it.
Yeah, it was nice. Yeah. So let's go to some of the live questions because some of them are going to blow y'all's mind, but some make sense. So I love the question from Isostasia at 11:45. I wonder for some moms having kids made their OCD less intrusive since they have bigger and more important tasks to focus on. As Liz once said, make your life bigger than OCD. So I know for me, this was the case. I know that for me, it kind of gave me a bit of a needed perspective shift and ability to say, you know what, I'm going to do that final work, right? I always talk a lot about how for many people with OCD, treatment is kind of the 70%. If I'm 70% better, that feels great. I can function, I can go to work, I can do these things, but I'm still dealing with some of my OCD because I don't really want to do that final work or do those bigger stuff or the final stuff that's there. What we all know is that 30% will grow. And that 30% will end up being much more than 30%. But for me, having kids really made me tackle that final 30%. And it really changed everything I believe around being able to get to freedom versus functioning with OCD. I wonder if you've seen that experience with other folks as well.
Yeah, no, and this is one of the things I love about doing this work is seeing people through this process and seeing people, and again, I believe we have these things for a reason. Like, I believe we have postpartum OCD, perinatal OCD. I believe we have postpartum depression for a reason. And it is really hard, and we need to make sure people are not alone and that they're getting treatment. But when you see people come through that, it does, like, people, if they get the support they need, they can come through that and see, like, it gives this kind of perspectives on things, and this kind of even more meaning to what they're doing and to their lives. And it's helped them think through that and, be thoughtful about those thoughts and what they serve and, all of that. So
100%. The next question is one that I think a lot of people might be blown away by, but 1147, how much training and continuing education do OB and ER providers receive regarding OCD?
I mean, this is something we need to change. We need to keep working on. I mean, as I said, we were just kind of getting people to start talking about postpartum depression, right? And which is great, but we're just starting to get like to the perinatal anxiety and then to OCD, so and it's hard. I mean, I did 2 years of an OB residency, and I know how much they have a lot they need to learn. They're learning a lot of things on how to, do deliveries, how to do surgeries. There's a lot there. So, it's hard, and that's why I truly have come to believe that this is about teams. This is about teams of people, and not one person needs to know everything. That we need to have teams of people that work together, and that people need to have kind of a common understanding of these things. Like, to have even that question is really doesn't take a lot of time to ask someone, or to kind of validate. A lot of parents have upsetting thoughts about their babies or intrusive thoughts. What kind of thoughts have you had? That doesn't take a lot of time, but then you need the team to be able to, if this needs to be talked about more, there needs to be intervention, then you need the team around you to help make sure you're not alone in dealing with that.
100%. Yeah, couldn't agree more. So I know we're cutting short on time, but I think the big thing I just want to make sure we revisit and close out with is that it makes sense that during big life changes, whatever they are, but especially in the perinatal period, so during pregnancy and postpartum, including dads in the postpartum period, that life, anxiety, and OCD can shift, can change, and can be disrupted. But what we also know, depression as well, of course, but what we also know is that treatment still works. And I think that's a really important piece I would love to end on is, does treatment still work when it is during this period in our life?
Absolutely. In fact, I would actually argue it may even work better because there is a lot of changing plasticity, and that plasticity not only makes us more vulnerable, but it also opens us up to like being open to new, like kind of change and, and so yes. And I will say we have work to do on we've got treatments. We don't always know the right treatment for the individual. We don't always know how to personalize it. And, and I think we do need to keep looking at these other biological components like the immune system and seeing if there are ways that we can come at it from that. But yes, absolutely. We have treatments that work, and we just, and for each individual to remember, like if one thing doesn't work for you, there will be something, and just stay in it with your team, and the team, stay in it with your patient. And
yeah, 100%. Yeah. Treatment works, no matter what phase you're in. And, the statement I love so much, you guys know, is that help and hope are always available. And I think that many times in this period, it just feels harder sometimes to pull yourself into treatment, and you've got all this extra responsibility on top of your own mental health. But it's critical to know that you're not going to be able to take care of someone else if you're not taking care of yourself. And we know that saying, and we know it's true. So help and hope are always available, and treatment works. Thank you so much for your time. I'll let you end with any final messages, but I hope everybody listening understands and can recognize that perinatal anxiety, OCD, depression is real, and it impacts so many people. But what we also know is that treatment still works, and that you don't have to continue to struggle and to suffer during this period. You can get help.
And I would just say, let's just keep talking. I'm so glad people have come to talk about this, and let's just keep talking about it, and, having us be able to continue to get more people talking about it.
Yes. Keep the conversation going, because that is how real change happens. So thank you. Thank you for your time, Mary. And thank you so much for the work and research that you do on this important, needed topic.
Thank you.
Thanks, y'all.